So thanks, Mike, and greatly appreciate the opportunity of being at this meeting and talking to you about high-cross CTOs. Now, unfortunately, like it was referred to that I was going to show you a lot of crossing gadgets. That's not my first way to cross these, but we will use some gadgets, and I'll try to show, I think there'll be a kind of complementary talks with the excellent talk you just heard. So, in 2014, these CTOs represent a significant proportion of the folks you're going to want to treat. Now, with experienced operators and the gadgets that we have and perseverance, the success rate is very high, such that crossing CTOs and treating them with endovascular is frontline for the majority of patients. And if you do it correctly, you don't hurt your surgical options. When you plan for a CTO, you think about how long's it been there? If somebody tells you last Tuesday for the first time I felt sudden pain, that's maybe embolic as opposed to atherosclerotic with chronic symptoms. How much do these symptoms bother somebody? If they don't bother them that much and it's a terrible calcified CTO, you can push medicines a little more first. Are the patient and family well informed, and you, the staff, and everybody well prepared for a long case potentially? And you think about some things on the angiogram that you've heard about, including what adjunctive therapy and what access route you're going to use. Now, some considerations before we get into cases. We don't want to take a CTO and extend it by dissecting it and propagating a dissection. So that's where reentry devices help. Remember anticoagulation. If it's a long case, we put them on a heparin drip so I don't forget and let that bolus wear away. If we do it right, it doesn't hurt surgical options. And you look at other things. Is there severe calcified disease at the reentry point and so on that may affect your success? And you must respect the profunda, the common femoral artery, and the popliteal arteries. You need to have patience, and you can get through most of these, or try again later. Access, you've heard about a little bit. For the majority of these, it's contralateral for us, but there are a lot of other options that can help. Antegrade, you can't use that for ostial disease because you don't have enough room. Popliteal is a little bit cumbersome, but can be helpful. Pedal, we use it sometimes, usually more for critical ischemia. But you can, and we do that just to cross the lesion and externalize the wire. Brachial and radial are absolutely impractical for most of them. Importantly, wherever your access, you're going to want a roadmap from above to get the collaterals in your roadmap to show you where you're aiming for. My strategy, I believe in crossing from above, if possible, with guide wires and catheters. I think I don't ever reach for occlusion or proximal device first. Ideally, as you've heard, you want to stay within the lumen. If we do get subintimal and we're making good progress, we'll go with it, okay? And just keep pushing carefully, of course. If you can't cross it, then we'll increase our support. Get the catheter right next to the occlusion, go to straight glide wires, etc., and then try a crossing device if we need to. If we can't cross from crossing devices or reentry devices, then we carefully reconsider, should we go retrograde, and should we do it today or another time? Now, when we go into these, the first thing I want to do is identify the nub proximally and distally. If we see a good nub and a good reentry, we pretty much know we're going to be able to get this most of the time. Put a ruler or tape on the leg before you do your first picture. It's a great reference to know where you're coming back to. We start with an angled glide wire and a quick cross catheter or CXI in most cases. Trying, as you've heard, to stay within the lumen because it gives you more options and it's more physiologic. If you do get subintimal and you form a loop, as was mentioned, you want to keep that loop thin, or small, and advance your catheter over it. You don't want that loop to ever get as big as the vessel itself. You can push folks pretty hard on these wires and catheters as you go through CTOs. And then you confirm your position. I personally have a low threshold for using distal protection devices for ugly disease. Here are some of my must-have tools, and they're catheters and wires, reentry devices, both ultrasound and not. We have laser anyhow, and that's a good crossing tool, as you'll see. And then the other specialty stents, especially when you get down into the adductor canal. All right, let's look at some cases to highlight this. Here's this CTO, moderate length. You can see some disease at the reentry site. Again, the first thing you want to do is identify the nub. That's usually just an RAO or an LAO, depending, the ipsilateral oblique. And here you can see the nub very well. Once you do that, you've got a sheath close. You use your roadmap, glide wire, and a catheter, engaging that. And then you slowly push with it. If it goes nicely, keep pushing. As long as you can get the feedback, and if it goes there, well, it'll go well, and you see the tape on the leg. Now we're going to make a road map from above, and then just steer into the lumen with our wire. And then you exchange and get to work. That view, the RAO oblique, is good for not only identifying the ostium, but for stenting the ostium at the end. Excuse me. And here's a final runoff for that case. Nubs, sometimes you have to be creative. A lot of times they're flush ostial. I still look for them. And usually you can go around and take several pictures. A lot of times we'll do a picture to see if there's anything here that actually looked like a profunda branch, that it's a nub. That wasn't the case here. But here's a lateral 90 degrees. Here's that nub. Okay, if you look, most of the time you can find it. You can also use vascular ultrasound to find it. And then you get an angled catheter, as was mentioned, to get across that. Sometimes you have to be a little smart and creative. Some of these times it's hard to know which one of these is your branch and which is the nub. So what we'll often do is take a subtracted picture and follow this. See this right here? That matches up very nice. So there's our CTO. Okay. Once you have that, back to our standard technique of starting with a wire, aiming it down here, and then crossing the lesion. Sometimes if there are bypass grafts, usually the medial one is going to be your bypass graft. And that's important because you really want to pick which one you want to fight, which battle you want to fight. If you have a lot of catheters, or excuse me, a lot of branches, and your occlusion is right at a branch, which it often happens, you often will use an angled catheter to direct, as was mentioned, and then sometimes a straight glide wire with the angled catheter. Now, CTO tools. There are those tools that cross the proximal cap. You heard those mentioned. The ones that we have are listed here. There are a lot of other newer devices. Okay, we don't have all of these, but some people really like them to stay in the lumen. And then re-entry devices, which I find invaluable, both the Pioneer with the ultrasound guidance and the Outback, and there's others available now also. When you use re-entry devices, they will shorten your procedure time. Those of us that were practiced for a while before them, boy, they make our life easier. They're 014 exchange length. You kind of have the L and T configurations in oblique views, and aim at the vessel and shoot. The wire should pass easily. If not, you're not in the right place. If it doesn't pass, pull it back a little, see you might be against the wall, and try the wire again. If not, just withdraw it, reorient, shoot again. There's no penalty for extra shots. Remember to withdraw the needle before you remove it and then get to work. So this is an 8-year-old CTO, and it's probably that little thing there at the ostium. Here's that same picture we showed you before, that probably is your ostium, and it's a long CTO down to here. Again, we use our standard wire technique, and we were able to cross, but couldn't get there. And again, you can see the L pointing at the vessel on a road map. You shoot, and the wire should go that easily, and then you pull the device out and get to work, and you're able to finish the case. The Pioneer device can be very handy. It's great for iliacs as well, but look at this case. Here's somebody who has a lot of hardware that I can't see, okay? And so with that, even with me contorting his knee every way I could, here's the occlusion. It's very hard to see, and I was caught. I couldn't get it with a wire, and like Jaffer, I also use 014, 018 in this territory and really want to stay in the lumen. If we're going to stay in the lumen and I can't see it, I can see it with an ultrasound. So the Pioneer will show you the lumen, and then you put your wire back in, and that's very useful in a situation like this. And then you confirm your intraluminal position and complete the procedure. Laser step-by-step and putting other CTOs. We're going to use several tricks for the last couple cases. This is a patient who I treated for 9 years with a CTO ostial, and he really wasn't that symptomatic. We treated him medically until he came with acute limb ischemia. So here was his CTO that was its flush ostium, and what caused his acute limb ischemia was the distal part went down. That's all he had left, and you can see that the occlusion goes all the way down to the trifurcation. And the surgeons actually put him on heparin and had me see him in the morning, Here's laser step by step. We couldn't cross. You see, first thing we did is get our sheath down there, really give good support, tried an angled cath or a straight glide wire, and it kept prolapsing into the profunda. All right. So I knew where the nub was. So here's a laser, okay? And we just stand on the laser and let it cross the cap that you can see right here. All right. Then you advance your wire down where you get resistance again. You pull the wire back into the device right here, and then give it a little burst of laser and cross the cap. Okay. Now, remember, this all he had left was this little island here, and as mentioned before, I completely agree. Once you get down here, you want to stay in the lumen, and I couldn't get in there here, so we have to get back into that lumen. So here's another device. We just re-entered into what I knew was the true lumen with a re-entry device. And then here's a V18 wire and a quick cross catheter, carefully going through the rest of the occlusion into the tibial vessel, staying within the lumen, and magging up, and another road map, and staying within the lumen. So with that combination of devices, you're able to take that long 9-year CTO and this acute limb ischemia and fix all of them. What about CTOs when somebody's already had a stent in? These represent some unique problems sometimes because if the stent is downstream in the leg, you have to stay in the true lumen to get to the stent, or you can't use a reentry device. So you've got to stay within lumen. If you can't get there the first time, just simply pull back and try a different angle and see if you can get there. If not, you can get fancy, as we'll see, with retrograde access and externalizing the wire or directly accessing the stent itself. So here's a gentleman who the first time around was a pretty easy CTO. And we cross with a glide wire and a catheter, and we put a interwoven stent in. And the first time around, we're high fives. Looks great. 2.5 years and a lot of cigarettes later, he comes back, and now he's got occlusion of an entire SFA. Here's his stent, and it's a very long segment occlusion. So try our normal, get through. It looks like we're doing well here. Here we go, push, push, there we go. However, you can see here, even with angled catheters, I could not get into the stent. So first thing to do is go back and try somewhere else. So, and you can see this is clearly a different plane, and I'm happy. I think, okay, I'm going to get it this time. Well, I couldn't. So here we went tibial access, and you can see with road maps from above, steering within the lumen. And now from below, we're able to get inside the stent from below. Now we're not quite done. I thought we were. See how easily it goes here. Again, Tex and I are high-fiving, thinking we're almost there. I could not wire this. It looks easy. Say, Chris, wire that thing. But remember, this is a subintimal plane, and I couldn't get it from above and below. We tried a balloon here. That didn't work. So here's some other things you can do. This is the finger of God type approach where a balloon from above and below, you kind of inflate them and disrupt the intima, and then try your wires again. Usually works. It did not. So here is a balloon from below, just bareback through the tibial vessel and a reentry device, and actually just puncture, something we learned in Leipzig from the Leipzig guys, and just puncturing the balloon. You can see it collapsing here. Now that wire from above is in the lumen of the balloon that you know was in the true lumen downstream. Then you can take your back out and simply push that wire into the balloon that you know is in the pedal vessel, and just have your tech work with you. And here you can see the balloon coming back with the wire inside it through the stent and into the tibial vessel. Now you're home free. Your work's going to be from above through that wire that you're able to use a technique for, and able to take that long CTO and recreate the vessel. And you can see the tibial vessel where the access, you can't even see where that sheath was. They simply hand pressure with all we had in there was a balloon. Some more tricks. This is a guy who I'd stented before. Here's a stent. And it was a little nuisance of a CTO. You can see that it really was right here, right after all these branches and this stent there. So we tried from above, and I mean, I tried hard. This is an angled catheter. You can see the stent magged up. I tried everything I could to get into the stent here, and actually couldn't do it. Now, you think how to get there? Access considerations. It's too close for popliteal access. and this guy had one vessel run off out of the anterior tibial, and he wasn't the most cooperative patient. So instead of going tibial on him, we actually just directly access the stent itself. You can see it fluoroscopically. Obviously, you numb him up pretty good and give him a little extra dose of happy juice. And then this is just a straight glide wire directly into the stent from below. So now you know you're in the lumen. Then you simply take that, advance with a support catheter bareback, and advance the wire. And here you can see that we're all the way up the SFA. Now it was a straight glide wire. I couldn't get the catheter. Normally we'd just try to steer that into the sheath. I couldn't get that, but we were easily in the true lumen. So what we did was we just advanced it into the aorta and snared it from the other side. We already had a sheath in, and just simply snared that wire. So now what we have is a situation where you have an exchange length wire. You just take a catheter up and around over that externalized kind of flossed wire, if you will. And then now you just take your catheter that you remember you started within the stent. So now you've got a catheter inside the stent where you want it to be. And then you simply take that wire out, cross it, and then fix the vessel from above like you were trying to do to begin with. And you see, again, he only had one vessel runoff, which is why we chose to go that route. So some final considerations. Other access can be very helpful, as we've heard several times, including antegrade, popliteal, pedal access. If you do retrograde access, it's usually just to get the wire through and then externalize it and work from above. Most CTOs are benign, so we have to use common sense. If you're struggling for 2.5 hours and not making progress, stop and fight another day. It's okay to stop and try again. So in conclusion, these CTOs are very common for anybody who does busy peripheral work. Most of them can be treated with endovascular first approaches by experienced operators who have the perseverance to go through them and for appropriate indications. And thank you, PK, and the whole staff for having me here. I appreciate it.